Hello everybody, I am Dr. Jindal here, Rajesh Jindal, medical oncologist from Medela Cancer Cure Center, Agarpada, which is in Kolkata. The topic for today discussion is metastatic colorectal cancer. However, I have truncated the topic slightly in the sense that I'll be talking only about metastatic colon cancer. We'll take up rectal cancer some other time, right? So what we would be talking about today is metastatic colon cancer, and so let us proceed with the topic. And first of all, like the incidence and all, as it is the fourth most common colon cancer is the fourth most common cancer seen in the country, with a large incidence, of course. And then I don't need to go into the statistics of absolute numbers and all, but however, what I would want to say is that the symptoms remain the same, which are rectal bleeding, pain abdomen, and altered bowel habits. Plus, add to this would be any symptom of the metastatic site. Say, for example, if the patient has got lung metastasis, he might have hemoptysis. If he's got an unusual presentation with skeletal metastasis, it could be bone pains and otherwise. So, but the main symptoms, the presenting symptoms remain the same, which are rectal bleeding, pain abdomen, altered bowel habits, loss of weight, loss of appetite. These things would follow. Now, because we are into stage 4 colon cancer, metastatic colon cancer, I would state that the most frequent site of mets is the liver, followed by lung and the peritoneum. Approximately 1/4 of all the colon cancer patients present with a metastatic disease. About 50 to 60% of these patients of colon cancer will eventually develop metastasis somewhere or the other in the body, and which in the order of frequency would be liver, lung, and the peritoneum. About 80 to 90% of the metastatic disease patients have unresectable liver mets. So we'll take up one by one as to what do we do with the resectable mets and what do we do with unresectable mets. As far as the workup is concerned, well, we do when the patient comes to us, presents to us, we will do all the necessary workup, HBT, CDC, platelet, biochemistry, renal function, ECG, echo, and other things. Do a biopsy, a true cut biopsy, of course, and send it for gene evaluation, RAS, BRAF, HER2 evaluation, because we have drugs against all of these now. Or better still, we can do an NGS so that we get the entire genomic profile of the patient, including the MSI status, and then to evaluate the organ involvement, let us do a PET scan on the patient so that we can know the exact extent of the metastatic disease and keep a tab on the subsequent response to treatment as well, maybe with a PET or maybe with other I would say supportive investigations. Now, what are the salient features of the metastatic disease? Well, the salient features would be that synchronous metastatic disease, which means that if the patient presents upfront with a metastatic disease, then this disease is likely to be more disseminated and it has a worse prognosis compared to patients who have metastasis later in the disease. Metachronous metastasis जिसको बोलते हैं. So synchronous versus metachronous metastatic disease, and you do have a change in the prognosis. Now, patients with liver mets who do not undergo surgery have a low 5-year survival compared to those who get their surgery done. Survival will also depend upon the presence of extrahepatic mets, say in the lung, say elsewhere, maybe in the peritoneum, elsewhere maybe, and if the patient has more than 3 mets in the liver more than 3 minutes outside or including the liver. And if the disease-free interval, this would be applicable for metachronous disease. So disease-free interval of less than 12 months, then the survival would also be compromised, because it reflects that it is an aggressive disease that we are here dealing with. Cure is possible in the patients with colon cancer who have liver mets. Now, patients undergoing resection may look into 20% 5-year survival. The median survival is, however, 38%. Solitary liver mets, however, and after surgery, the 5-year survival may be as high as 71% in some series and in some established centers who would do this kind of surgery and this kind of treatment on a regular basis. Now, the same recommendations of surgery, number of mets, solitary liver, solitary lung mets also apply to lung mets. So, in lung mets also, surgery is first choice if it can be done, that is. The 3-year recurrence-free survival in the liver for lung mets is 28%, and the 3-year overall survival is 78%. Now, with resection of hepatic and extrahepatic mets, the results seem to be equivocal. I mean, if the patient has both hepatic as well as extrahepatic mets, then the results seem to be equivocal. However, recently improved results are being reported if the patient is resected for extrahepatic mets also at the same time. This could be probably because of the improvement in the surgical techniques, as well as the supportive care and the aftercare afforded to the patient after the surgery is done. Extrahepatic mets, however, as we would understand, are a poor prognostic sign, and the recurrent mets both in the lung and the liver may again be operated, but then the 5-year survival will fall with each subsequent resection. So now let me outline the treatment of the metastatic disease, I would say. So let me first put behind me the local treatment, and local treatment for the liver, because they are the ones which are most amenable for local treatment, and there have been a lot of studies and a lot of ways and means in which these things have been handled. So the first, or let me start with the earliest of the local interventions, which used to be radiofrequency ablation, microwave ablation, cryoablation, and electrocoagulation. So all these therapies were used. They are still being used in some centers, but they are not so popular anymore because we've got other therapies which have come, replaced them, more effective, and so on and so forth. So the first therapy that I would want to elaborate is the hepatic arterial infusion, HAI. Cannulate the artery, find out the afferent artery into the tumor, into the secondary of the liver, and then we cannulate that artery and we infuse directly the drugs through these arteries, through this arterial infusion into the metastatic SOL. The drugs used are fluoxuridine plus dexamethasone, and simultaneously an infusion of FFU and leucovorin is also given to these patients. The greatest advantage of this is that, of course, we would expect that the lesion would resolve completely, but the other advantage of this therapy could be that an inoperable lesion is converted into an operable lesion. Then you have TACE, transhepatic arterial chemoembolization. In this, again, hepatic artery catheterization is done, and excuse me, the drug used are irinotecan loaded drug eluting beads. So this is a drug which is used. These are drug eluting beads, like you have drug-eluting stents in cardiology. Here we have drug-eluting beads, which are the artery which is leading into the tumor, which is leading into the metastatic SOL. It's clogged with them. It is actually embolized with these drugs, which keep on eluting irinotecan out of this thing, and then it goes and kills the metastatic cells. Here it has been seen that the OS benefit, the overall survival benefit compared to FOLFIRI is about 7 months. With TACE, you get an overall survival advantage of about 22 months, whereas with FOLFIRI, which is a combination of 5-fluorouracil, irinotecan and leucovorin, you get an overall survival of 15 months. So this is the advantage of TACE. Now you have SIR spheres also, which can be used for radioembolization of the same thing. So it is called radioembolization, and the seeds, the isotope uses yttrium-90. These beads are again used via the hepatic artery. That artery, we go into the afferent artery of the SOL, of the hepatic SOL of the metastatic lesion, cannulate that artery, and then we inject yttrium-90 radioactive beads. And they would yttrium-90 is a beta emitter. It has got an extremely short range. Beta particles have an extremely short range in tissue, and that range is confined only to the metastatic site, with very little scattered radiation or radiation beyond the SOL. And but then the results of these two techniques will depend upon the CEA level, which is an indirect reflection of the tumor volume, whether the patient had lymphovascular invasion at the time of surgery, the tumor volume, like as I said, with the which will correlate with the CEA level. Then comes extent of the disease in the liver. So all these three parameters reflect about the same thing: the CEA level, the tumor volume, and the extent of disease in the liver. Then comes the bilirubin and the albumin levels, which goes to show the function of the liver as well. So these are the things which we can use for local treatment, starting from radiofrequency ablation, microwave ablation, cryo, electrocoagulation, followed by the other things would be hepatic artery infusion, transhepatic arterial chemoembolization, and transhepatic arterial radioembolization of these lesions. Now, patients who cannot or will not undergo something of a local treatment like this, they don't want any invasive procedure. Well, what we can do is to offer them SBRT, stereotactic body radiotherapy. The limitation of stereotactic body radiotherapy is that it should provide adequate margins around the site that we would want to irradiate, and that all the lesions in the where we aim to focus SBRT should be treatable, or they should be treated. If you have 3, 4, 5 scattered lesions in the liver, then you just can't treat 2 out of 3 or say 4 out of 5 and leave the rest to be taken care of by the systemic therapy. It cannot be done like this. So SBRT and the local treatments, even otherwise, are employed if we can use or treat all of them together. So this much was for the local treatment, and now we come down to surgery. Although I'll be able to enumerate only surgery, I'll not be able to enumerate the surgical technique, of course, being a medical oncologist. So what do we do for resectable mets? Well, for resectable mets, now the thing is, either we do a synchronous stage colectomy. In that case, we do the surgery upfront, remove the tumor, remove the secondaries at the same surgery. Then at the same time we can do the lung and liver resection, of course. I mean, if it is a metastatic disease and we want to do a synchronous stage colectomy, synchronous procedure at the same time, right? Or we do a stage procedure in which we do a colectomy first, followed by lung metastasis removal, liver metastatic removal, and then we follow it up with local treatment. So either it can be synchronous surgery, everything together, or we have a staged procedure, colectomy first, followed by the resection of the metastatic size. So this much was surgery. Now some patients can be rendered operable after about 2 to 3 months of neoadjuvant therapy. Now the neoadjuvant therapy 2 to 3 months can be either FOLFOX, it could be Capox, which is oxaliplatin, leucovorin and 5-FU for FOLFOX. Capox, it is oxaliplatin combined with capecitabine. FOLFIRI, you have the same combination of leucovorin, 5-FU, plus here you have irinotecan instead of oxaliplatin. Or you can have, if there is a very aggressive treating team, they can use a combination called FOLFIRINOX, which is a combination of all the 4 active drugs in a GI malignancy, which are oxaliplatin, irinotecan, 5-FU and leucovorin. So the first choice would be, however, neoadjuvant therapy with 2 to 3 months of FOLFOX or Capox. Now FOLFOX, as you know, is given every 15 days and Capox is given every 3 weeks. So that is how we do. Then there's another choice in the sense that we do colectomy first, follow it up with chemotherapy, and then we do the resection of the metastasis. So it is primary surgery of the primary site first, followed by adjuvant therapy. That adjuvant therapy, we hope, would take care of the metastasis also, and if the metastasis also respond to the extent that they become operable, then we have another resection which will operate the metastatic disease. Then comes a choice called for tumors who are MSI high, who are microsatellite instability high, and they can be used with a combination which does not employ chemotherapy at all. We can use a drug, pembrolizumab, available as Keytruda, or we can use a combination of nivolumab and ipilimumab, and then depending on the response, then we could go in for surgery, and it could be again, surgery could be of the primary, of the secondaries at the same time, or maybe spaced apart, so that you can have surgery depending upon the response and the general condition of the patient. Now, what do we do with unresectable patients? Sorry, I forgot the one thing which I needed to add, that in all the choices 1, 2, 3 which I said, either it is synchronous surgery, or you have stage colectomy followed by lung and liver mets, or you have upfront neoadjuvant therapy followed by surgery, or you have colectomy followed by chemotherapy, and then a stage resection. All these three kinds of treatment, they will need adjuvant treatment after the surgery is done. Okay, so all these things would still need adjuvant treatment after the surgery. But then the last choice, which was MSI high tumors treated only with immune onco agents, they might not need any chemotherapy after the surgery is done. But that again will depend upon the extent of surgery and the extent of the response and the extent of the residual tumor that we have found upon surgery. So unresectable metastasis which cannot be operated, how do you go about dealing with that kind of a disease? Well, that kind of a disease, what we do is we use chemotherapy combinations which I have already enumerated above, which could be FOLFOX, it could be Capox, combination of oxaliplatin or capecitabine, or a combination of oxaliplatin, 5-FU leucovorin, it could be FOLFIRI, it could be FOLFIRINOX, depending upon how aggressive the treating team wants to go and how good is the general condition of the patient. For both sides of the colon, for right side as well as left side, we may add bevacizumab, VEGF inhibitor, bevacizumab. Bevacizumab is preferably added to the right side of the colon, because the left side of the colon will still give you good results with cetuximab and panitumumab if the patient is KRAS wild type. So if you have a colon cancer which is of the left side, KRAS wild type, then I think we would go ahead and use Erbitux in those patients, which is cetuximab, or we can use bevacizumab also on the left side. On the right side, even if the patient is KRAS wild type, the drug of choice, the monoclonal antibody of choice would be bevacizumab instead of cetuximab or panitumumab. Then comes again, if the patient is MSI high, then we can still use pembrolizumab or a combination of nivo-EP, nivolumab plus ipilimumab for any kind of tumor which is MSI high. Now, in recurrent disease, what if the patient has a recurrent disease? We've given him 6 cycles of K-pox, we've given him 6 cycles of FOLFIRI or say whatever. The patient responds but he recurs, or the patient never has a complete response. Then what drug do we use now? So the idea of using these drugs, or the idea of using all these 4 drugs, is that whichever drug we have used before, now we will not repeat it. So that if we have used K-pox in the first place, then FOLFOX after K-pox makes very little sense. So in that case, we would use a combination with irinotecan. So we will use irinotecan and maybe 5-FU-leucovorin, or if the general condition of the patient does not allow, then only single drug irinotecan. But then cetuximab also is a very good choice, using single drug only for palliation. It's not going to do much by way of in the combination, because you've already used the combination before, but it is a good drug for maintenance therapy and for palliative therapy. The other drug which can be used is maybe regorafenib, which is an oral drug, 160 mg per day, difficult to tolerate, difficult to use drug, but then if there is no choice, then I think we can use regorafenib as well. The other thing which I said during the workup earlier also is that we do an NGS, an next genome sequencing in these patients, figure out the genome, figure out all the actionable mutations in these patients. Now, if we have a drug against a specific mutation, like as I said, if we have a drug against BRAF, then we can use the drug. And if we have HER2 new in these patients, HER2 new positive in these patients, then of course we can use Herceptin, trastuzumab, or we can use trastuzumab deruxtecan, which is being used for patients which are HER2 new positive. Now, when and how do we do an NGS? Well, NGS, we would, if it is upfront, then we have the tissue sample with us, then I think it should be done on the tissue. It gives you a lot more information about the tumor, so we will send it by blood, by the tissue. But if tissue is an issue, as we say, then we can do it on blood. They would extract the circulating tumor DNA from the blood, do an NGS, give us the genomic profile of the patient, and then if we find any actionable mutations in those in that report of NGS, then I think we can go ahead and use whatever drug comes out through that NGS report. Recently, there was a report about an immune therapy drug, dostarlimab, giving 100% results in colon cancer, metastatic colon cancer. Well, small series, but very encouraging results, needs to be followed up, and we need larger studies with greater number of patients to see that if the results are actually reproducible. A word about peritoneal carcinomatosis. The approach is palliative. We can use systemic chemotherapy for these patients. Any of these combinations will do. Capox, Folfox, FOLFIRINOX, any of these combinations will do depending upon the general condition of the patient. And we can also do something called HIPEC, which is hyperthermic intraperitoneal chemotherapy, in which chemotherapy solutions raised slightly above the body temperature are infused into the peritoneum, circulated, drained out, and then seems to be giving us good responses. But then so do the number of side effects, and these things also are encountered much more with HIPEC. It is being used, but of course not so popular, because the IV results produced are nearly the same as you have with HIPEC therapy. So I think this is all as of now for all the metastatic colon cancer. Thank you very much.